अस्सलाम वालेकुम जी, मैं हूं डॉक्टर नुमान नियाज।
Hello, hope you're having a good day. I'm Dr. Nauman Niaz and you're watching my channel, DNN. Today we'll be discussing diabetes mellitus in a different perspective. First and foremost, this talk is not only going to be restricted to my patient population, those who are well conversant or those who understand English, but it is also for the up-and-coming endocrinologists, the diabetologists in the making, the consultants and the postgraduate trainees, even the general practitioners. We all know that diabetes is primarily a metabolic disease. If I take a pause and make you stimulate your auditory pathways or bring your cognitive mind in the fray, I may well say that with modern therapeutic options available, diabetes is no more a disease, but it slides your patient into irreversible complications and the target organ damage, which eventually impedes the quality of life and impacts negatively on the patient population. So let us be very clear that when it comes to diabetes, the first fear of the patient is the state of self-denial. So as a physician, as a clinician, as a diabetologist, it's not only identify the type of diabetes your patient is suffering with, but it is imperative and more important that first and foremost, very important, to make them realize that they are suffering from diabetes. If they control their numbers, if they control the sugars, and if they modify their lifestyles, rest assured they live normally without much impediments coming in their way till they live. So that's important. You have to develop that trust level, and as the clinical practitioners, it's not only about dispensing the prescriptions, but more important is to empathize, and empathy is, I think, of integral importance when it comes to dealing with your patients. Now, another thing which is important, that we at times tend to treat our patients as clients. We are not businessmen, we are not the corporate executives. We are there to serve the cause of humanity, the fairness of virtue and the greatest blessing that the man may be able to comprehend. Therefore, empathy, I say in apostrophe, that it's the tool with which you shall have excellence in your careers. Now, types of diabetes, first and foremost, diabetes is a metabolic disorder where you have high glucose levels, whether they are preprandial, that is fasting, or postprandial, that is after meal. And type 1 diabetes, we all know, is not that widely prevalent, but still there is no insulin, virtually no insulin being produced by the pancreas, the beta cells in the pancreas. So early insulinization becomes important and significant. Another important aspect is that some of the medical students and the postgraduate trainees, they come up and keep on asking that whether the sensitizers are required in type 1 diabetics or not. I personally feel that like in Southwest Asia, which includes Pakistan, 92% of our population has insulin resistance. Approximate number is about 92% of us, we are insulin resistant. So if you have a strong family history, and it's not necessary that you have been diagnosed to have type 1 because of the absolute pancreatic failure, and if there is no beta cells producing insulin, you may well have an element of insulin resistance, as you call that. That is because of the genetic predisposition. So a bit of an admix where we have to contemplate the insulin resistance part as well. And generally speaking, you will now come up with fancy GLP-1 agonists. Well, they are important, but they are not, to me, they are not the core of diabetic treatment. and their use in type 1 diabetics may well still be ambiguous. More importantly, it may well be required where we know that the patient is having insulin resistance and the type 1. We may well try with basal insulins, long-acting insulins, but at the end of the day, I shall keep it very simple, which we will discuss eventually when we come to the therapeutic part of today's talk. Now moving on to type 2 diabetes. Well, I'll take a pause. We must know that it was as late as in 2017 that the world population of diabetics was about 450 million. And it has been projected to reach about 629 million worldwide by 2045. So now if we see that the type 2 diabetes, I think it covers 90% of the total diabetic population. So type 2 is most commonly which you need to treat in your private clinics and hospitals, in your diabetology departments, in your departments of endocrinology. So now, coming up to type 2, it's a very simple phenomenon that there is insulin resistance, which is intangible, but we can still actually help the patients out in this regard. So, as I said that in Southwest Asia, we have 92% of the population suffering from insulin resistance. Second predicament is the type of diet which we are accustomed to, and we are at times indiscriminate. And I always tell my patients that, well, if you are a diabetic, doesn't mean that we are giving you the diabetic diet. It is actually the most sensible diet one should be taking, and what we have been taking prior to being diagnosed with diabetes was an absolute junk, and we were not doing any favors to ourselves if we keep health in mind. So now the diet, the problem with us is that we are accustomed to taking saturated fats. Then we take chapati, which is like wheat, and which is carbohydrate. We combine it with protein, that is meat, and then we want our cooking to be done in open utensils. So the oil or whatever we use, the oil, the high density lipoprotein, because of oxidation, that evaporates and that just goes away, and we are left with junk that we eat. So pressure cooker cooking may well be recommended. Closed utensil cooking may well be much more healthier still. Now, we are talking about the mechanism of type 2 diabetes. Well, we know that the pituitary gland secretes sex hormones, the glucocorticoids, and they're degraded into polysugars, and we have sugars. So that can be one part daily basis we are getting the sugars from. Then the adrenal gland secretes again glucocorticoids, breakdown, we will have high glucose. Coming on to the pancreas, because of the genetic predisposition or an absolute pancreatic failure, you may pancreatic exhaustion, you may well have low insulin levels in the body or no insulin levels, and if their insulin like as a policeman as far as the glucose production is concerned, so therefore there will be no policeman, there will be low insulin, you will have high sugars. Then the alpha cells, they produce glucagon, a hormone which is released even if you haven't started to eat, but you are just contemplating to drink a glass of water, a glass of juice, or to take something. So glucagon shall be secreted, and the moment it is released, it releases sugars, and that becomes another source. Going on to the type 2 diabetes pathophysiology, we also know that the liver is like a factory in our body. So it produces many vitamins, protein synthesis, whatever. But sugars are produced through a process called gluconeogenesis. So if there is no or less insulin in the body, we'll have increased hepatic production of glucose because of the gluconeogenesis. So that is another predicament we have to deal with. Then we have the lipids within the liver, and even with minimal activity, we stimulate a process called lipolysis. And what happens is that polysaturated fats are produced, and eventually we have higher sugar loads in the body. So that's the basic mechanism, and that is the reason I'm a great admirer, as well as I'm the man who recommends, who stands behind the concept of early insulinization. Now, let me clarify that about 25, 30 years ago, well, we had synthetic insulin being produced from animal sources, and eventually you had to have that needle pricks, U100 syringes and like U40 syringes, and you were injecting, and then the hypoglycemias, the nocturnal hypoglycemias. Then patients, if they delayed taking the meal, they could land in problem. So it was not an easy thing, and it was normally taken as the last treatment option. Now I'm using the word last treatment option. I personally feel with the genesis of these analog insulins, now insulin should be our first priority as endocrinologists and as dermatologists, and early insulinization probably is the way forward. And now it should be termed as replacement therapy. It's almost like replacing the hormone, which is not available inside your body. Now, moving on to another type is the gestational diabetes. Again, it is often overlooked, but you'll be shocked to know that almost 223 million women suffer from diabetes worldwide. And it is estimated, it is projected that by 2045, the women with diabetes number shall rise up to like 323 million. And 16% of these women during their fertility years, some or the other have glucose tolerance or such problems, and gestational diabetes ensues. So 16% means almost 20 million women they undergo the gestational diabetes, which is another type. And then we also have to keep in mind that the babies they are going to produce, they may well be overweight, and 99% chances that they'll turn into diabetics. And of course, the women themselves, in 8 to 10 years' times, in 8 to 10 years' time, they just slither into type 2 diabetes. So mostly the women with gestational diabetes eventually are going to end up with the disease itself. Then we discuss about maturity onset diabetes, a little perplexing, because now what we understood that by the end of the third decade of one's life, or the start of the fourth decade, one used to be diagnosed with type 2 diabetes. Now I have seen young people as young as 18, 20 years old, 25 years old, just having high insulin resistance and type 2 diabetes. So again, the lifestyle changes and this paradigm shift is quite thought-provoking. Now moving on to LADA is obviously it's because of the immune response that you tend to have high sugars in your body. And then secondary diabetes, it can be a sequel to complicated pancreatitis. It may well be seen in alcoholic pancreatitis. Then the steroid therapy, there are certain drugs, the steroids, they can cause hyperglycemia. Then, of course, there are certain antipsychotics like olanzapine having proclivity towards raising blood sugars in one's body. So secondary diabetes is just like we have to be very, very savvy about it. Now, coming on to the fact that what you need to tell your patients. Number one, you have to convince them that they have diabetes. You have to ease them out psychologically, emotionally. You have to empathize with them. You have to give them time. You may well have to tell them what is actually wrong with them. You may have to, not like in literal terms, but with simpler phrases, you have to explain the pathophysiology. And then, of course, you have to make them ready to accept your therapy. And before you examine the patient, you also have to keep in mind that these young doctors, they should know that it is normally said that 5 years prior to the diagnosis of type 2 diabetes, microvascular damage has already started. Then also, there is a social concern that people, they get into the number game that, my random blood sugar is 340, it's too high. Well, yes, that should leave you concerned. But at the end of the day, I personally feel it's also about the glycemic variability. And that's the reason I am a practitioner who tries to convince the patient to shift to insulin as early as possible in the disease, to delay at least, if not to restrict the ensuing microvascular complications and the irreversible damage which a patient is going to have, as well as rest assured that glycemic variability is as bad as uncontrolled sugars in the body. Now, what should be our benchmarks? It differs. Obviously, diabetes is a disease greatly impacted by the race, the ethnicity, even the demographic. Even you see different trends, different trends worldwide in different countries and different continents. So at the end of the day, we have to see. We have to restrict ourselves to our environment where we are practicing, and we have to cogitate and contemplate the best way forward. Obesity is a crime in a diabetic, and unfortunately, in Southwest Asia, particularly in our country like Pakistan, we come across with majority of the diabetic population also having the metabolic syndrome. There is no concept of hip-waist ratio, and then of course. The central obesity, indiscriminate dietary habits, sedentary lifestyles, and BMI of almost more than 35. They're grossly overweight, and then the diet. They have no concept, and these are the predicaments one faces when we deal with such population. So obesity is also a concern, high uric acid, dyslipidemias, high cholesterol, high triglycerides. So normally you come across then strong genetic predisposition, strong family history. So that adds to your woes as a clinician. Now, what to do? So one, we have to ease the patient out. We have to empathize. We have to convince them. We have to have a better doctor-patient relationship. And then we have to prepare them with diagnostics. Now, so I personally feel if you have a naive patient and a new patient in your clinic and recently diagnosed diabetic, you may well have the C-peptide levels done. You may well have the insulin levels done. This will help you identify the insulin resistance part. And of course, IGF-1 levels. And then more important is obviously fasting blood sugar 2 hours post-prandial. And of course, we do not have the 24 hours glucose monitoring available that commonly in Pakistan. So we have to stick to HbA1c, which has become grossly controversial, and its standardization has been questioned worldwide. But let's see that how it is going to come up again and find its place back in diagnosing diabetes and making assessments, logical assessments and contemplations. So that is again another thing. Then renal function tests. You should have. You should know the baseline levels of urea and creatinine, and of course cholesterol and lipid profile, because mostly we are dealing with comorbidities such as dyslipidemia, hypertension, and then early diabetes. So that you have to keep in mind. And once you have gone through this, you should also clinically examine. It's not only about examining like doing the cardiac auscultation or auscultating the chest. You should also either get the fundoscopy done or do it yourself, Then, of course, you have to check for the peripheral vasculopathy, the peripheral neuropathy, and even you have to ask questions about gastroesophageal reflux or autonomic neuropathy if it is coexisting. So that is more important. Once you have made the assessments, then now comes your prescription. Well, you have bigonides, and including metformin, commonly used, very well tolerated. About 10% of the total diabetic population may well complain or may be intolerant to metformin, having nausea, gastric symptoms, vomiting, diarrhea. So 90% they're fine with it. In our population, metformin is quite of integral importance because it also helps in weight loss. Then sulfonylureas, they are still being used, worldwide being used. And I'm not a great fan because of you have long-acting sulfonylureas such as glimepiride and hypoglycemic episodes and the liver, and the impact on the liver, the effects on the kidneys, so the renal impacts. So I'm not a great fan of sulfonylureas, but still, they're one of the better and cheaper options. Then you also have the pioglitazones. Again, the drug has become controversial. We saw rosiglitazone being its use being prohibited by the FDA because of the cardiotoxicity and cardiac effects. We also heard many other things about pioglitazone and their impact on being the precipitating factor in the bladder tumors and prostate cancers. Well, I still feel that there is a weight gain if you use pioglitazone. They are remarkable sensitizers. Then, of course, we have SGLT inhibitors now. We have DPP4 inhibitors, and we also have GLP-1 agonists, more fancy. I personally feel I'm not going to discourage you all not to use GLP-1 agonists, but I see very little or no role in type 1 diabetes. In type 2, if they are tolerated, because some of them, rather most of them, they tend to give the gastrointestinal side effects, nausea, vomiting, diarrhea, even constipation in some cases. And of course, they are attractive because of the fact that it is being projected they help in weight loss. Well, there have been studies saying that you could lose 4 to 5 kgs, but I personally feel, one, its cost effectiveness in Pakistan, because we also have to keep in mind the economic and the financial status of our patients coming to us. And secondly, they're fancier still. I feel that, 5 kgs of weight loss in a patient with a BMI of 35, 38 or 40, which we deal. Maybe you could say that pragmatic use, okay, fine, done. You have many types of GLP-1 agonists. You have exenatide, you have dulaglutide, which is once weekly. You have liraglutide once daily. Exenatide was twice daily, once daily. You could use once weekly. You could use, and then of course you have lixisenatide again once weekly. When it comes to talking about GLP-1 agonists, now we are also having the combination of long-acting basal insulin, that is deglutide, along with liraglutide in one injection. Again, the use of such combination in our population may well be trickier still. Moving on to the other aspects, you have now insulins. You know about non-analog insulins, in which you have short-acting, intermediate-acting, long-acting insulins. You have rapid-acting insulins. And then, of course, you have combination insulins with long-acting and short-acting. Unfortunately, in Pakistan, what I have seen so far, that is the indiscriminate use of 70-30, regardless of knowing the meal size, the dietary habits, the lifestyle, the need, the requirement, whether you're dealing with preprandial hyperglycemia or you are dealing with postprandial, you do not have. Normally what you do is that uncontrolled sugars, and you tend to start the insulin therapy 70-30. Maybe there's a requirement of 20/80. Maybe there's a requirement of 30/70 rather than 70/30, or 50/50, or 75/25. So on and so forth. Then, of course, we have basal insulins. I think these has been revolutionary in the management of diabetes. You have primarily two types. One is the Datamir insulin, uh, which is like not purely a 24-hour insulin, uh, but you can say its effect lasts about 18 to 20 hours. I wonder why couldn't we use it twice daily, because it is weight neutral. Generally, the insulins, they have a tendency to see some weight gain in the patients. So then we have glargine insulin, we have U100 glargine, we have U300 glargine, and I think it's a fantastic basal insulin. It gives covers for almost 24 hours. Then, of course, we come up to another important factor once we are dealing with insulin. But before I get into it, I should not forget telling you that if you are using GLP-1 agonist in patients, then you do not use the DPP-4. I wonder what happens to the glucagon part of managing the diabetes then. And generally, now we get the DPP-4 like sitagliptin or vildagliptin combined with metformin, sustained release metformin. So I think that is wonderful when it comes to give a comprehensive cover and protection to your patient. So I won't mind using a basal insulin in my new patients, and metformin combined with either sitagliptin or vildagliptin. I shall not jump onto SGLT2s unless until I require to reinforce the prescription that the patient has gone on short-acting and long-acting insulins. We are already on metformin and DPP-4, then I may well see that there may well be a need creeping up for DPP-4 by SGLT2. Now, another important thing is that generally there's a tendency to not use long-acting sulfonylureas along with insulin. It may well not be recommended, but at times it may well be required. So you don't say that if somebody has written glimepiride with insulin has gone berserk, but it is normally the therapeutics, the therapy in diabetes is individualized and optimized. So you also you are the best judge. You have your patient, and there is not like one prescription for every patient you have in your clinic or in your hospital. So that you have to keep in mind. Then again, another thing which you should keep in the fray is like use of insulin secretors. So riplimide being used with basal insulin. Well, I have been doing it in my clinics, whether there are the recommendations or not, and I have had fascinating results in my patients. So again, this could be another approach. Then coming on to the combination insulins. Of course, you have 50-50 mix insulins, you have 30 insulins, you have 25, 75 insulins combinations, and you have, of course, rapid-acting and short-acting insulins. So now we also have in our armory like a D-gludac insulin, which is a beautifully made 24-hour like basal insulin, and in one injection combines with a short-acting insulin. Maybe tricky because it directly correlates to your patient's dietary habits, the meals they take. Generally, we say for a diabetic. Now, coming on to that, I have discussed, I think, wholesomely the use of insulins and oral hypoglycemics in different groups. Another thing which you should keep in mind, that mostly your diabetic population, they are also having dyslipidemias. So starting with statin, and then of course, if there are high triglycerides, then you have to get into the, obviously, other groups as well, phenofibrates, etc. Then use of aspirin, I personally feel, unless until there is a requirement, there is a serious risk of a patient developing cardiovascular disease, only then initiate aspirin therapy. It should not be prophylactic. That is how I have been getting in terms. with managing my patients. Then, of course, you also have to keep in mind there's certain oral hypoglycemics which may not be indicated because of the renal clearance, the renal failure. So metformin, well, I don't see any reason that you should put the patient or continue the patient on metformin if the creatinine is 1.6 milligram per deciliter or more. So that you have to set your benchmarks. Then, of course, in renal failures, you have to titrate the insulin. I'm not going to get into the 303 rule or something like that. But more important is that you have to titrate the insulin. And the reason is that your patient may slither into hypoglycemia. If it comes to like basal insulin, the analog insulins, I could assure you that nocturnal hypoglycemia or hypoglycemic episodes, they have been marginally reduced now. Obviously, you don't jump into 20 units instantly. You have to give like increments of insulin in your patient population. You have to explain to the patient that the moment they start insulin, it's not going to directly impact and lower their blood sugars. It may take a week or two because of insulin itself being a hormone shall require sensitization, and it takes about a week or 2 weeks before you start titrating and making rapid assessments. So this is another part. Now coming on to the exercise, well, kinetic and akinetic exercise, weightlifting, because you also have to see that intense strenuous exercise may actually tamper with your lipids and cholesterol in the body. So I personally feel then cardio-dynamic exercises are totally different. Running is something different. I personally feel that moving your limbs while you are walking, and a brisk walk is going to help you because the muscle demand of glucose shall increase, and there will be greater intake of uptake of glucose by the muscles that will help lowering down your glucose levels. So I think moving all limbs like an army man, a soldier parading across, so that shall be much more invisible. Now getting on to the dietary things, caloric count, carb count, if you can't do it, okay. First and foremost, like you can have the king's breakfast and then a white-collared lunch and a poor man's dinner interspersed with 2 snacks. Because if you're on insulin, then you also have to be like cognizant of an impending hypoglycemia. So you have to avoid that. Hypoglycemia is not going to help your heart or it's not going to help your brain. You have to avoid the hypoglycemias. And the significantly hyperglycemia with sugar of over 400, persistent over 400, if you have ketones in your urine, ketosis, you are in trouble. So you have to also be vigilant about not slipping or slinking into diabetic ketoacidosis. So then the complications we shall discuss some other time, but to just make it easy for you, a big no to saturated fats. Carbohydrates, you have to calculate calories, you have to calculate if you're a diabetic, and then of course no saturated carbs, and you can take no saturated fats, and you can take unsaturated fats. Now saturated fats include your butter, etc., and if it comes to unsaturated fats, that will include an avocado, nuts, a whole grain, that is important. Juices, a no to fruit juices, and there are certain fruits which you should avoid, includes mango, grape, figs, dates, and if you have glycemias or hyperglycemia, try to avoid banana, otherwise you can take rest of the fruit, but not the fruit juices. Artificial sweeteners I shall not recommend because it's only about the taste it develops. You adapt to your changing lifestyle and it becomes healthier still. Now, last but not the least, when it comes to sweets, no sugars. They're not allowed, no sweets, no bakery items. And obviously, you also have to keep in the fray, you should avoid large servings of rice and a no to fried rice. You can have boiled rice, but a palm size Then going on to, there's a big no to fried peas and fried potatoes. That means French fries. There's a no to fast food. You can have grilled food. You should not have fried prawns, but because they're very high on LDL. But you can have steamed or baked prawns because they're a very good source of HDL, high density lipoprotein, which is healthier still. Lastly, you should also keep in mind that the portion of your meal should be adequate. You should not starve. But at the end of the day, that should be within the framework of the calories defined or identified for you a day. Lastly, about the dry fruit, I think peanuts, walnut, and almonds, they are recommended, but generally, rest of the dry fruit is not going to help your diabetes. I hope that I made some, I tried to express myself, my clinical clientele, the way I treat diabetes. And before I leave, I must say that it's not that the physicians or the clinicians, they do not have the knowledge. It's about empathy, one. And two, important is that you have to designate some time to your newly diagnosed diabetics, and even on regular visits and regular checkups and follow-ups. And I personally feel that it's not about not having the knowledge, it's about that writing the best prescription. And the best prescription is not like having the fancy and expensive drugs or the high on quality drugs. It's like what is indicated in your patient. So that should be kept in mind. I assure you on my channel, I shall be even discussing diabetes in Urdu for the masses. And also, we will discuss in detail the complications. Like there are newer studies about the ACE inhibitors, the ARB during this COVID-19 pandemic, about captopril, the use, it's not being encouraged. So we have loads to discuss, and we shall be doing it. It was just like the preliminary talk on diabetes and the way forward. And fasting sugar, ideally between 90 and 100 milligrams per deciliter. That should be the target. Random blood sugar, 135 to 150 milligrams per deciliter. HbA1c should ideally be between 6% to 6.5%. Obviously, there are studies now coming up of how you have to cater for the patients, like HbA1c of 7% or 7.5% or less than 8. That's another debate, but keep it in mind between 6 and 6.5%. Serum triglycerides less than 150 milligram per deciliter. Serum cholesterol less than 150 milligram per deciliter. If we get on to HDL, it should be more than 40 in men and more than 50 in women. And then VLDL should be lesser than 31, and LDL should range between 70 and 100 milligram per deciliter. These are the targets we need to achieve. Hope to see you again, and I wish you all the best. And I also just want to help the newer generation of clinicians coming up. Take good care of yourself. Goodbye.